This is the DocNation podcast. We are a movement founded by doctors, for doctors, dedicated to empowering medical professionals to reclaim control over healthcare decisions and advocating for their fair share of the industry's resources. Please note, the views expressed are those of DocNation and not necessarily those of our guests or referenced health centers. Welcome back to DocNation. Today we are talking with Dr. Joe Norris, an orthopedic surgeon with a passion for innovation. He spent years specializing in knee and shoulder surgery, led a major orthopedic practice, and even built and sold a cutting-edge sports performance facility. On top of that, he's the founder of multiple healthcare companies focused on improving surgery, wellness, and education. We'll dive into his journey, the business of medicine, and where he sees healthcare heading. Let's get started. Joe, tell us about what are you up to nowadays?
Oh, Justin, that's a can of worms. First and foremost, I just want to say it's a privilege and an honor to be on DocNation. As of a couple days ago, I'm not just a podcast guest, but I'm also a member. Could not be prouder, and I'm really excited about everything you guys do. I really appreciate you. I don't know if you hear that from physicians enough, and I'm gonna do everything I can to get the awareness out. For you guys and of you guys. I think from where I'm at right now, and what I've kind of thought about leading up to this discussion is kind of the two lives that I lead and have led from the beginning of my practice as a businessman or entrepreneur and a practitioner that cares so much about what I do with respect to surgery in my profession and passion. Where those kind of started separately and where they intersected has really guided my journey into how I practice, where I practice, what I want to try to do to help the problems that we face. And my lens is always, I can't help it, from somebody who wants to solve a problem, stand it up, create value, and then understand what that value is. And so what I'm doing today, I am practicing in a lot of different ways. I'm a co-founder of a business. I'm a real estate investor and developer. I just, you tell me where you want to go, and I'll go that way. But there's a lot of things that I do, and I wear a lot of hats, and that's intentional. I really enjoy a lot of different things, but my core is treating patients and doing surgery, and I still love to do it as much as possible.
Well, I think about your story and going back in time and compare that to what we're seeing today, which is 75% of medical students are on antidepressants and stimulants. And you've got the suicide rate being double among physicians compared to the rest of the population. We're not in a good, how is a community going to get healthier if the people who they're looking to for the help are struggling themselves? And I want to get your perspective. You've seen what it's like to be on the employed side, but also being self-employed. And what can you speak to as far as what do you see as that has been unraveling over the years? Because you've been at practice how long? How many years?
Oh boy, 2009 was my
9.
first year, so 15 years.
Okay, 15 years. I mean, has it changed? Do you think from when you started, or what
Oh
would you say?
man. Yeah, I guess I will start there. When I came out, I was in a private practice, decent size, mid-sized group, 10 surgeons, amongst other practitioners. We did everything that orthopedic surgeons do when they get together. They buy a magnet and have PT and have some ancillary service business lines. We then, I grew a practice, and kind of treated it like my own little profit and loss P&L business, in addition to the whole group going out and really taking big swings. And we built a 60,000 square foot medical office building as part of a wellness center, and really did some things that helped scratch an itch for me as trying to be an innovator and a president of our private practice. By the time we got all the way there, I will tell you, I felt the burden, and it wasn't because I was doing so many projects and different things with medicine. It was because when you create the machine, you got to feed it. So you get the PA, you get two PAs, now they depend on you. Their
Mhm.
families need you to pay them, and you got to see more patients because you're getting paid less. And I really felt on the hamster wheel, man. And
How
one
many
thing
years in? How many years into it were you?
uh, that was 10 years in, just
Okay.
a practice that people would have killed for. Super busy in the middle of the Midwest in a honeypot of great commercial payers, insurance companies with their national headquarters too. It's perfect, right? Um, I was not feeling fulfilled. I would get up and I'd be like, ugh, 55 patients in clinic today. And it was kind of like taking loose leaf paper and putting it in front of a fan and then all day just picking up the papers. And I did that. I just finally decided, and my wife and bellwether that helps me every step of the way. We just decided. We just literally took everything we had, all the wonderful things from the outside looking in that were just perfect, and we picked up, pulled stakes, and moved. And I went from president of a private practice to being employed in another state and having a completely different lifestyle. Um, One, for the experiences of my kids and my family, but two, looking back at it, I think I looked at the next 15 years and thought, man, I'm just not going to be the happy, uh, you know, fun-loving dad, friend, surgeon that I want to be and treat my patients. So I, I I changed it because I in a way felt it, but it is scary and hard for physicians to do that. I totally admit that and understand it.
That's impressive because I think a lot of physicians are very scared of change. And I think a lot of people use that against physicians. Would you say you were burnt out? Is that what, an overarching term that has been used out there in medicine a lot? I think I feel it every now and then. I think every physician feels it every now and then, where you get up and you kind of do the same thing every day, and you're just walking that same road.
Yeah, I imagine you would probably say this and agree or disagree. You let me know. I don't think that we identify it as burnout. We don't understand what that means. We just know that we used to get up and be challenged and oh man, this this reverse total shoulder today is going to be a blast. And even the stuff that's so exciting and so fun and meeting new people and helping them solve their problems and feel better, you don't, and you lose the enjoyment. And then I felt that I was a little bit of a different person. I'm never in a bad mood, and I felt like I was in some bad mood. So in
Mhm.
essence, I didn't know it was burnout, but I would say, yeah, I think a lot of it was burnout, and this is where it intersects with the other parts of my life, whether it be faith, but also business. And I got really frustrated with the business side too, and just because I had other businesses that I can completely understand and follow normal rules of business. And so you solve a problem, you create the solution, you create value, you get benefit. And also it's a fee for service that an accounts receivable is steady and known, and your costs don't vary. It was impossible to try to solve. And so I decided to kind of commoditize my skill set and practice business in things that were consistently following the right rules, I guess, from what I want out of that interaction with how to create value and make more money. But it also helped me go down the path, which I'm happy to talk a little bit about because I haven't heard it on your guys' previous podcast. Um, Having an entrepreneurial mindset, one thing that I don't want and don't like is when physicians are playing a victim. Physicians are some of the smartest individuals in our country,
Mhm.
and we need to solve problems. We need to not complain and bitch and say, "Oh, woe is me." We need to say, "How are we going to take control of this situation?" I've gone down that path of solving some of those problems, and I think there's a future for it.
I think that's a great point, Joe. I think a lot of physicians don't think that the problems can be solved, unfortunately. And that's part of the reason, we have DocNation is we're getting physicians together, like-minded physicians like myself and you that says, hey, let's bring the problems to the top and let's try to solve them. And I don't think people realize like the hospital systems, they want to work with you. Even insurance companies, I think right now or see the writing on the wall that this needs to change. It all needs to change. Healthcare in America needs to change. And everyone wants to work with us. We just physicians, like you said, do a lot of complaining without a lot of action, and that frustrates me a lot.
And I have so I went down the path, again, analyzing why is it frustrating for our compensation because it's a Pandora's black box of not
Totally.
and a physician who doesn't even understand what an Excel spreadsheet, and I don't disparage that. I think that physicians, if they're not interested in it, they should do what they want to do. But because I was very interested in it and I gained a lot of knowledge, I started thinking about all the different costs and how to eliminate it. And the first thing that I come to a conclusion is, what if someone came to me and said, "Hey, how much does it cost you to do a knee scope for me?" I would have no idea, right?
Yeah,
That's
So
right.
yeah.
the first thing we got to do is understand our costs and then what margin we would have. And that's where I believe we're coming to a consumerism of medical care. And instead of saying this is ridiculous, you know, you push me down and make me work harder, and then I'm judged on metrics of am I nice? Do they enjoy the interaction? And it's not, hey, I'm a surgeon that has great outcomes and no infections. But because of that consumerism, in my opinion, again, let's lean into it. If you're a consumer and you're paying cash, because it's all high deductible payments anyway for a lot of medical care,
Right.
if
Yeah.
we can create a business model where we know our costs and we can give you a price sheet. If you look at, for instance, the Surgery Center of Oklahoma, I don't know if you guys have looked at that as a case study before. They're an all cash ASC and they contract with employers. The employers have 80% less costs for outpatient surgeries, and that surgery center absolutely kills it. The surgeons love operating there, and the patients love going there. Um, it's a there's even networks that connect all of these people who do understand the costs that they have and the revenue they need to create to keep their business afloat. I worked with a guy named Dr. Jawad Arshad that created Wow Health, and it's a network digitally of all of these providers, and you can go on and be like, how much for an MRI? And if it's cash, well, it's $350. I paid more in a copay because that place charged the insurance company $1,500 with an agreement to pay 800. I'm responsible for all 800. We got to take control. And I think
Hmm.
consumers, I hate to say that, they're patients, but they know what they want. They know their costs. They know what they would be willing to pay. Now we got to come to them and meet them halfway. I think that's part of a solution, potentially cutting out the middleman and all the bureaucracy and red tape.
Do you see your colleagues talking about consumerism within healthcare? Is that a term that pops up?
I think again, because of the circles that I travel in outside of medicine, I think that they talk about it, but not using the same
Words.
vocabulary. They
Okay.
talk about shopping, and that's a
Yeah, yeah,
consumer, right?
yeah, yeah. Okay.
And then the patients talk about the feel. I came to you, Dr. Norris, because I went to the Behemoth orthopedic group and I felt like a number and I was a cattle being herded. But
Yeah.
you took time and I got in and so on and so forth. So the short answer is I think that without knowing it and talking about it, they do understand that that's where it is. Patients are officially consumers of our care.
Well, I think there's a huge push towards concierge medicine, at least where I'm in South Florida. And that's exactly what that is, right? Is you're paying for access, you're paying for more time, which equals better care. And unfortunately, I mean, when you started practicing, there was more time, which I think
Mhm.
equals better
Yep.
care. A big push you kind of said in one of your statements is see more patients, see more patients. And there's reasons for that. They need to, the cost of doing things are getting very expensive and the reimbursements are not getting better. But there is a side effect of seeing more patients, seeing more patients. We just don't have the time. I don't think physicians don't want to spend the time with patients, they just can't. And that concierge medicine has allowed that to happen. And you're seeing it first, it started in primary, and now you're seeing it even in orthopedics, which is interesting.
Do you know any of the, because I don't personally know any of the concierge medicine doctors. Are they happier with that situation too?
Oh,
They
oh,
enjoy it?
100%. And they always said it was very scary. It is very scary starting out. So a lot of the concierge medicine docs refer to me. And it's interesting because I kind of have to tell the patient, like, hey, I'm not concierge. I can't get you in this afternoon. I'm sorry. But they understand that. But the concierge docs that I know very well said it was very scary to do it at first because they didn't know if there'd be a market. But once they get their patients in and they're happier, not just financially, but how they're doing medicine, right? They feel like they're being a physician again. So it's interesting to see the concierge market picking up down here and how successful it is. And then I think patients enjoy it too. I feel bad for patients that have health insurance and are also paying for a concierge doctor because you're kind of paying, twice for the same thing. But they really enjoy it. The patients like the access. It's all about access now. And unfortunately, I think that's what it's going to become is paying for access.
Dr. Norris, let's go back to what you said about knowing what things cost. Let's can we talk about that from a across the board all specialty standpoint? If if everybody who's tuning in is going to say, okay, I'm going to take what Dr. Norris said, I'm going to go back to my clinic, back to the practice, whether it's private practice or employed, I'm going to go start to really get clear on this. What would be some action steps? Because I think you're right. They're completely clueless because it's intentionally built to keep them in the dark. So if they want to have all this stuff, the data come into the light, what, how would you advise them to do that?
So I think that the federal government actually started exposing this specifically just to orthopedic surgery now. They created a shared savings program for anyone in the country that helped specifically one phase of care, which was post-operative care. So um, unfortunately, we all know that if you give rules, some entity may leverage that. So they found that these, for instance, after a total knee or total hip or a hip fracture, they were staying in these skilled nursing facilities for exactly 19 and a half days or whatever it was because 20 was allowed.
Yeah.
And they said, hey, surgeons, if you help take control of this problem, we'll give you half of everything that is saved because it's not great care. Patients don't need to be there for 2 weeks, 3 weeks. So they actually gave it, and we maxed out our benefit in huge revenue savings or cost savings, I should say, but revenue to our practice every quarter. So then we started diving in the people who the individuals or groups that understood that.
Yeah.
And the couple that are really innovative. One of my friends and colleagues is the CEO of a large group in the Chicago suburbs. He is the godfather of understanding risk because that's what we're talking about, right? Going what they call at risk. So that is the doctor saying all of a sudden, and then another concept, at least in my world, and it's a lot of different specialties, is bundling, right? So you bundle all the costs, and this is done with third-party payers, and say all of a sudden now, instead of to the patient, to the third-party payer, or to a employer that's self-insured, okay, we're going to bill, it's going to be $80,000, $90,000 in bills for a total knee. How about this? You pay me $40,000 and I am the group. I do the PT, I do the surgery. We are the surgery center. I pay the anesthesia. I pay the implants. We do it all. Well, 50% savings for them. And if you understand your risks and costs, it's a hugely profitable thing for the groups that do it well. But you're going at risk because if that patient has a complication and it turns into $90,000 of care, that's on you. So yeah, I didn't answer your question, and I'm trying to get around to it. I think understanding costs gets granular, um, but it's very achievable. And you have to, the best leverage that we can do is to own the entire vertical of care.
Hmm.
So a vertically oriented care. So if you, for instance, in primary care, if you own the lab, I have control. If you're a surgeon, if you have a surgery center, I have control. And you've talked about that a lot on a lot of your podcasts, and it's autonomy. And it seems like big risk, and it is, but there's a reason that you get enough orthopedic surgeons together or surgeons in general and you buy a surgery center. You realize that, hey, there's a site of service. It's got to happen.
Yeah.
Who's better at controlling the flow of care, the quality of care, and then get an upside on the revenue? You
But are
know,
you talking about just in a private practice setting, or is there a way to apply that in an employed setting?
um, I think that in an employed setting, you're dealing with a different animal because I do think you give some of the autonomy away. Um, if you have and this is again, I am not adversarial with any of the administrators that I've ever worked with. And the one that I work with currently in North Carolina is innovative and wonderful. And he's giving us a seat at the table at building a surgery center in an MOB. And he's leveraging the expertise of people that have been there. That's wonderful. But I do think it is dependent on the person or the entity, the group that you're working with. But I do think that you have to have a voice, and you do, because you still hold a lot more cards than you think you do. Um, and and to that point, Justin, I would also like to say when I went from private practice to being employed, I I think one of the businesses or not the ideas, the help that I would like to provide to doctors that are either going straight employed and they've never seen private practice is
Uh-huh.
to really understand their value. Because I know what a surgeon can produce in revenue a year based on this RVU and this payer mix.
So you're
It's
talking total collection, you're talking the revenue coming in, the collections that they're producing?
Yes,
I
but
mean,
I but I also know the downstream revenue created by every physician. You all order labs, you all order CTs, MRIs, physical therapy. All of these things is a revenue source
Yeah.
for that entity. And that you can't officially, legally get a piece of that pie.
Yeah.
But hey, don't
But
be after the
the house is rewarded for it. And so if the house is getting it, then there ought to be some recognition for that versus pretending
and
as if it's completely separate in someone else's territory.
that's one of the big things we talk about is knowing your worth. And even as an employed model, I think people don't understand one, how much you actually do bring to the hospital and ancillaries just by being there. And two, how hard it is to replace you if you did leave. You have more leverage than you think you do. If you're unhappy, if you're happy, great. Keep doing your thing. If you are unhappy though, don't just go in a hole. That's what DocNation's here for is you have more value than you think you do. If you're unhappy, it's probably because you're undervalued. The hospital's not going to come to you and say, "Hey, we know you're undervalued, so we're going to kick it in." Just you have to go ask. And this is what was saying before. They want to work with you. They don't want you to leave. It's unless you're a terrible physician having bad outcomes, they want you to stay because it's really hard to replace you. It's not, you don't just take physician A and put in physician B and the machine keeps running. So knowing your worth, I'm glad you said that. It's one thing we say so much to doctors is know your value, know your worth.
and and as a we're more than a cog, but also understanding what your options are, especially if you're coming out. Justin and I have spoken about this in cross paths. For other reasons this came up, but I had the opportunity to work in a critical access hospital. No one even really understands what that is. And I wouldn't have. I'm not like I went out and searched it, but now that I have that knowledge, I really want to share it with everyone I possibly can. So a critical access hospital is a specific designation to a hospital that requires you to essentially be rural or rural access, critical access. You have to be under a certain number of beds because you can't be a big hospital. You have to be further than so many miles away from another hospital, so on and so forth. And the federal government recognizes that that is a need, and we have to take care of these patients in these communities. So they essentially, from an accounting perspective, negate their costs from their books and they increase their revenue and subsidize them to essentially 1.5 of Medicare and Medicaid. So they can make Medicaid profitable. And if you're with a very savvy administration and they get it, they pass along that increase or bump, and all of a sudden you get a small little hospital. The hospital that I worked at in Illinois, we are doing the craziest cartilage transplants. These surgeons are doing total femurs. It is amazing what can be done. And the patient and the physicians always want to stay, great retention, because they're feeling valued. It's like, hey, you know what? We're making more, you make more. It seems like who wants to live in the middle of nowhere?
Mhm.
Well, it's a pretty good life. And so I just want to educate physicians on what are your options, you know? And I think it's not all doom and gloom. There's some nice little pockets where we're still okay. And the sun will come out tomorrow.
That's great to hear. Well, before we wrap up, tell us about what's on your background. This oval thing. What is this?
I told you I'd started a lot of companies. This is the crown jewel. I'm a co-founder of a metabolic testing and movement prescription company. That sounds pretty vague. I'll tell you, we use a specific biomarker of lactate, and through that, we put individuals through a test then gives them an index of how metabolically flexible they are, meaning what fuels you can use. So, do I use fats, carbohydrates, and proteins, and how well do I use them? And then we prescribe through an application exactly based on their physiology where they should be in what zones. So they are maximizing their benefit and improving their metabolic capacity. So it's been a big undertaking. We are now in health systems and self-insured employers, and we're just seeing a lot of people having their lives changed without taking a shot or a pill. We're
Mm.
giving them the
Yeah.
power to actually utilize their own physiology through movement in the right way and the right level to really see change and affect all all cause mortality, all cause morbidity, all disease. It all comes down when you improve your metabolic behavior.
So is this for athletes or sports related, or is this for anybody?
So the short answer is, of course, it's for everybody. But you know, we're our the first, you know, the first problem to solve is the morbid obesity and really poor health,
Mm.
highest cost to our healthcare
I
system.
see.
Again,
Yeah.
talking on DocNation, and also the people who need it the most. We are one of the sickest countries in the world, as you had mentioned initially, but it doesn't necessarily have everything to do with healthcare. It has to do with our habits. And the
Habits.
problem that I think most people have is that they don't have direction. And this is to answer your question, it's probably the sickest or the morbidly obese, what we would call a Metflex index of 20 or lower, which means you
Okay.
have 4 times higher risk factor of a cardiac event. And
Gotcha.
but of those patients, those clients, I would say that, you know, what is the biggest impact that you can have? And I always think, hey, I could do a heck of a lot of shoulder surgeries, and I think that those patients are better off for it. But if you can touch, you know, with a scalable, you know, actual digital tool
Mhm.
to instruct you on how to move and what your metabolic behavior should be and how to grow it, it just seems like we could impact more. And the real market, it's not a marketing ploy, but I did coin it. You need to work less hard to see better results, is usually what happens. People are out there flipping tires and doing ropes, and they're like, ah, screw this, I'm done with it. It hurts. And really, what they need to do is they need to walk, and they need to walk every day.
Yeah.
Okay.
But they just have to go in their right zone, doing the right thing. And that's my mission outside of medicine right now.
I think that's inside of medicine. I think there's a huge push inside of medicine to get people healthier. I mean, I'm PM&R trained before I went into spine and pain, and you know, PM&R, that's what we're all about, is getting patients moving. And we lost that somewhere. Our habits in America somehow, like we were the only country that really lost it that bad. And everyone says Europeans are healthier because of their healthcare system. I don't think it's the full healthcare system. I think it's more what we're doing outside of the healthcare system. But we need to bring things like what you're doing into the healthcare system to say, hey, this matters more than doing an injection, more than doing a total shoulder. Yes, we can fix problems when they come up, but why don't we try to fix the whole problem? And I'm hoping we're taking that head on. I mean, I know we never get political really, but a lot of news has been out there about trying to lessen what we put in our body and understand better what we put in our body. I'll say it that way. Understand better what we're doing and understand better how to be more active and, and use our time wisely. So that's great. I'm excited to hear that you're doing that.
Yeah, it's more than a passion project. I think it has to go. But to your point, I've been fortunate enough to be in Europe, and when you're in Italy, we love to say, well, Italians, they just eat pasta and drink wine, and they are doing great. I'm like, yeah, but I saw a lot of bike racks
They're
and people
walking.
pretty much walking and
Yep.
biking everywhere too. So
Yep.
maybe that's part of it. I don't know.
Yep. Yep.
I see all the time. We're in Fort Lauderdale down here. It's flat and it's nice weather. There's no reason we can't have more bike lanes and walking everywhere. I mean, we'd be a great place to start doing it. Maybe in the summer it'd be a little hot, but I mean, we got to get moving, and it's hard. It's hard sometimes, the systems that we're in.
Have either of you seen the videos about the La Sierra High School in California and what they did back in JFK days? JFK was big on movement, and I wonder if that was the turning point. It was during that time, because if you look at that school and what they were doing, in our school system today, they are completely void of what La Sierra High School was doing. You can go Google it, go search it. If you're tuning in, go look up that video, watch it, because they were producing every class graduating warriors, like shredded. They were like totally bad to the bone, men and women. It wasn't just the men, it was the women too. And they had, to your point, the habits, the culture, the lifestyle. They had a whole grading system, kind of like in martial arts. You go from one color shorts to the next level color of shorts, and you graduate. And you wanted to, the culture was compete and get better. And you wanted to be able to have the top tier color short because that meant that you qualified. And we're so far away from that now. So I think there's many different forces that are at play here. But Dr. Norris, thanks for jumping on here with us. And selfishly, I want to talk to you on the side. Can I go get tested? I want to see what fuel does my body need? Because many of us are athletes and we like to do athletic things. And so it's is there a little bit of an edge that I can get on my next race if I got a little bit of oval involved? I don't know if that's a possibility because I'm maybe on the other side of things, but thanks for being on the show with us.
Of course. Loved it. Really enjoy it.
This has been the DocNation podcast. If you like what you heard, be sure to subscribe, rate, and leave us a review on Apple Podcasts, Spotify, or wherever you are listening to us. Your feedback really helps us reach more listeners like you. We'd also love to hear your thoughts and any topics you'd like us to cover in future episodes. Don't forget to follow us on Facebook, Instagram, and LinkedIn for updates, behind-the-scenes content, and to join the conversation. Thanks for listening.